I'm Mickey. Some of you may have heard me get up and ramble on before, but I only have 15 minutes, so I have to get on topic really quick. All right, so here's our objectives for today. We're going to identify an overarching goal of vascular access. What does that mean? It means I don't have the overarching goal for vascular access, but I think I have a pretty good one. We're going to look into safety and efficacy, and I'm going to start my timer. There we go. And we're going to discuss the importance of securing the catheter tip, CVAD catheter tip, in the right place. All right, so what I believe is an overarching goal of vascular access, you can see if you believe this also, is that we want to expertly, that's us, provide the patient with one vascular access device that will serve them until the end of need. Can I get an amen? Okay, cool. All right, we're going to go through this again, so you will be tested. All right, so how do we do that? How do we expertly provide one catheter that will reach the end of need? And for this talk, we're talking about CVADs, but I believe the same holds true for peripheral IVs. So we want to place the right, hopefully it didn't rip off my mic, we want to place the right CVAD in the optimal position, okay? And then we want to secure that in place, makes sense. We want to minimize complications that we can minimize, those we can actually control. And then we want to simplify care and maintenance. Why make it difficult? So how important is it to dwell the tip of the catheter in the optimal position? I could look over there and see a lot of people who want to help you with that, okay? And there's probably several talks. So we want to get to the lower 1/3 of the SVC, or the CAJ, and if you're coming up from the bottom to the IVC, above the diaphragm. We all agree with that? It's pretty important to get it in the right place, okay? And we know that a suboptimal placement is going to increase risks. Okay, you're following along. So look around over there and look through your app and say, how many talks, how much money could you spend over there to get the tip of the catheter in the right place? All right, I mean, ultrasound, some sort of tip terminating technology, let alone the education, the time to precept somebody and to really do it well, okay? We spend a lot of money, and we should, to get it in the right place because we know that's very important. But how much money or how much thought goes into keeping it there? Whatever's in the kit, okay? All right, so anchoring it in place. How important is it to keep the vascular access device in the right place? Well, internal movement. So you've got this catheter in, it's beautiful, and hey Mickey, didn't you know that it moves all the time? If your patient's breathing, you hope. If their heart is beating, thank God. And maybe they're out doing activities of daily living, they're moving their arms, they're walking around. We cannot anchor it inside yet. But we can work on the external portion, okay? So external movement, can we affect that? Well, yes we can. There's a number of options over there that'll tell you that it does that, okay? We want to eliminate pistoning, migration, dislodgement, retraction, all of those things. There is an anchor that will help you with that. Okay, so let's think about the time. How much time does it take you to get the right catheter expertly placed by you in the right place? Even if you include all the assessment you did beforehand and the charting after. It can be measured with a stopwatch, all right? Now, how much time does that catheter need to remain in place? That has to be measured with a calendar. But yet we put a ton of time and money into getting it to the right place, and securement is an afterthought. Just so we're all speaking the same language, this comes right out of INS, and this is the definitions of various securement devices. You have adhesive, you have integrated securement, I think it should say dressing, but they haven't asked me, subcutaneous securement system. I get to say Securicath. I never get to say a brand name. That's very exciting for me. And tissue adhesive, okay? Then there's a couple of improvised securement device. See the talk at 2:45. Suture-based securement is not a securement. It's labeled for wound closure. I could go on for 30 minutes at 2:45. Or creative taping, which we have all done, and we've seen some like, what are you thinking here? Yeah, just add more tape. Okay, so we're going to talk a little bit about safety and efficacy. Safety and efficacy from the FDA, basically, there's a definition there. I'll let you read it. But it says, is what you're doing going to solve more problems than it creates? You know, that. And if you did nothing, would you have the same outcome? And I think we can all agree that we need to secure it somehow. It will fall out if we don't do anything. So, okay, that question's answered. Now, how can we do more good than harm? All right, we're going to go into that. Okay, so we did this tiny little systematic review. Anybody ever done a systematic review or meta-analysis? Great fun. These two here were involved in it. It is a lot of work, and but you get to learn stuff from it, and I'm going to tell you what we learned from it. So when we looked at securement and the safety aspect of a securement, this is what we thought. Securement has a role potentially in these things. All right, it has for the patient insertion site issues, potentially CLABSI, thrombus, MARSI, and then with a clinician issue, obviously that improvised device we call suture-based securement, there's a risk to the clinician. All right, and efficacy. Well, what should be an efficacy measure for securement? It's sort of in the name. It should secure the darn catheter, right? Yes, yes. So we looked at migration, dislodgement, also care and maintenance. Securement can have an effect on that. And then reaching the end of need. And I know a lot of studies look at, did you finish the therapy? But that definition kind of goes all over the place if they decide to stop early because the line fell out. Did you just decide you didn't want it? But for end of need, it's the patient doesn't need it anymore for whatever reason. Some it's end of life, some it's end of therapy. Sometimes it's we had a PICC line for a short time and now we have a port. So there's lots of reasons. Basically we want to know that one catheter you put in, did it reach to the end of need? That's pretty much the message of every talk here, right? All right, so in the systematic review, great fun, we looked at all kinds of studies. We cast the net so wide, I mean, wide. And we were looking for a primary endpoint for safety. We chose CLABSI because, you know, you can't go to this conference without talking about CLABSI like every minute. So we thought that would be something that everybody looked at. And then for efficacy, obviously, migration and dislodgement. I'm not going to go into this, but just look at the bottom. We started with over 8,000 articles. Good time. And we got it down to 39 that actually had information we could use. That is very sad. All right, so I went over safety and efficacy. These are the endpoints we were looking at. Now, hang on, don't be shocked. Sutures won the lowest infection rate. How many believe that's true? Yeah, that was actually because we looked at it, and what was not happening was a differentiation between suspected, oh, they spiked a fever, let's pull it, and laboratory confirmed. And the older the study was, the less they looked at it, okay? So this is garbage, which is what you find sometime when you're reviewing systematic review. We need to do better at this. Okay, so just to throw this out there, there was a very good paper done by Mark Rowe, don't know if he's here, where he looked at, there he is, yeah, where he looked at almost 8,000 patients, and this is what they found. That was a 288% increase in relative risk of CLABSI found if they use some sort of adhesive securement device versus, I can say it, SecureCath. Great fun. Okay, so migration and dislodgement. We put those together. I wish we could have separated them. But think right now, since I can't use too much time, what's your definition of migration? 1 centimeter, 2 centimeter? Doesn't it depend on the size of your patient? Neonatal or larger? Doesn't depend where you put the tip in the first place? Yeah. So to me, migration is, if I have an optimal position that's right at the cable atrial junction, I migrate in that lower 1/3. I can still use it, it's still in an optimal position, but it's migrated out a little. What's a little depends on the size of the patient, right? Past that, it's dislodgement. How many of your hospitals actually use that definition? Okay, they didn't in the studies either. So we had to use migration and dislodgement together since that is the primary purpose of securement. Okay, so in this we had good data. And I know, yes, Mickey, of course, because it says secure cath. No, that's because that's what the studies were for, was to see if it migrated or dislodged. So we expected to have good numbers here. And you can see that secure cath, subcutaneous anchor securement system, did really well, okay? We didn't have enough information on either of the slides for tissue adhesive as securement. There we go. So, mission accomplished. So, how likely is it that one catheter you choose will be the only catheter the patient needs? It depends on your choice of securement. One of the things that we want to do also is simplify care and maintenance. With a secure cath, it stays with the catheter, one secure cath, the whole time, till the end of need. So you don't have that panic moment, and if you're a nurse or somebody who changes dressings, you know those moments. Are they going to sneeze, cough, roll over, whatever, is that thing's going to fall out? You never have to worry about that with the secure cath. It's the only securement that stays with the line for the life of the line. Okay, so when do you want to choose a secure cath over a different securement device? Always, because I'm up here for them. But the reality is, as a clinician, I used to say, well, let's get to the first dressing change. But if you look at the systematic review, you will see that some of the lines were falling out at 1 day, 2 days, 3 days. So unless you have a crystal ball and know that they're not going to, up that amount of Rocephin for 3 more weeks, then just put it on. Secure it day 1. You don't know when the patient's going to step on their IV line. All right. Retrospective study real quick that's in the process of publication. Basically, we looked at over 1 million catheter days, over 9,000 patients, and this was the difference. And these are people who had their catheters for 150 days, 160 days, a long time, okay? So if I'm the patient and I get to choose that I have a 98% chance of just having one line secured with a secure cath versus a 80% chance of losing my line, not much of a question, is it? Maybe we should get the patient's opinion on what they would like their line secured with. Okay, so in the Clatterbridge study, obviously secure cath, there were 2 different adhesive securement devices used, and they did much better with secure cath. All right, what do we remember? We want to expertly place one vascular access device to serve the patient till the end of need. These are 3 studies. This is kind of the synopsis here. We have Rose study with a 288% increase of risk of collapsing with an ASD versus secure cath. We have Bell's systematic review, Bell and a few other people, where secure cath had the lowest incidence of migration and dislodgement. And we have the Clatterbridge study, which I just went over, 98% versus 80%. Doesn't seem like much of a choice. And I didn't make it up, there's references. And you have these little cards with a selfie of me at a Colts game. Okay, yeah, that's all I have. And they have QR codes on them. And if you have questions, which you may, or you just want to chat, we'll be over at booth 612. Okay? Thanks for listening.